Hi, my name is Elizabeth Cohen, and I'm the senior medical correspondent with CNN. And I'm so happy to be here and so honored to be hosting this event with the U.S. Secretary of Health and Human Services, Xavier Becerra. He started out as a lawyer advocating for people with mental illness, and then served 12 terms in Congress from his home state of California. And then he was Attorney General in California, and now the U.S. Secretary of Health and Human Services, the first Latino to hold that job. So welcome, Mr. Secretary. I poured a glass of water for you.
Thank you.
Okay, so it's very dry. We need to stay hydrated, yes. Well, thank you so much for joining us here. We really appreciate your coming here. I know you have a plane to catch, so we will get right to it.
Perfect.
So you and I were talking earlier, and you told me that last month you were at the G7 meeting of health ministers. And did you all figure out how to avoid the next COVID, the next pandemic? Did you figure that out?
We're actually getting much closer, and right after G7, I went to Geneva because the World Health Assembly was meeting, where we had the global group assemble. And there actually is a concerted effort to come up with a pandemic preparedness accord that would let us deal with these types of issues on a global basis, because no one wants to go through this the same way, and everyone agrees. No one is safe until everyone is safe. It's just getting there is tough.
What infrastructure doesn't exist now that could exist that would make that easier, that kind of international cooperation?
Actually, think of it this way. 50 states in our union all do healthcare differently. If you were at the talk yesterday, I mentioned this. Imagine 150 plus nations, all of them doing it differently, all of them less than coordinated, all of them rarely sharing all the data they should. It's trying to stitch everyone together so that we can communicate well. We know where to go. There will be some who will be more ready than others to jump. And we want to make sure that we don't get some support to those that are less prepared too late, simply because they're not as ready. And so it's a coordination issue. It's a matter of sharing data, and there's still some issues. We wish China would share more data with us on any number of things, including the origins of COVID. And we have to make sure that we give people capacity, because people are tired of just hearing that the US will come out and save them by producing the vaccine that first you give to Americans, then they'll be ready to get it themselves. So they want capacity as well. All those issues are there. We want to make sure that there's coherence in governance. We want to make sure that if we're going to really do stuff that takes American tax dollars and sends it to help other countries, that it's going to be used well and that we're going to produce results. But perhaps the most important thing, Elizabeth, that I should say here is that America's back. And the great thing is, for about 4 years, we were not in the game internationally, and it was felt. And people are thrilled to see America back playing at the international level. They do have a question if we're going to stay. And our job is to let them know that we really do plan to stick around.
Speaking of the origins of China, the Wall Street Journal has done some reporting this week about a researcher, an individual in Wuhan, who had symptoms that would make sense with COVID and other diseases in November 2019. Does this help us figure out the origins of COVID? And if not, what's gonna help us answer that question?
If we can go further behind that information, first to find out if it's accurate, and secondly to get deeper insight, then yeah, sure it could help. But if that's the only thing we get and we don't know if it's true, it makes it very difficult. So transparency is obviously very important here, but just the collaboration. And if we're going to get there, I think healthcare will be one of the ways we do get there with countries like China, because while we may have our differences when it comes to geopolitics, at the end of the day, pandemics, these viruses don't care if you're Chinese or if you're American, they're going to hit. And so we have every reason to work together.
Can you give us any behind-the-scenes look into what the U.S. government is doing to get China to be more transparent?
No. But I can give you some hints. The fact that Secretary of State Blinken was there, the fact that we continue to make overtures, the fact that we actually have a very robust health operation working day in, day out as we speak with China is a sign that there is work, there is cooperation, there is some collaboration, but it's not at the levels it would need to be, especially because China is such a big player today in the world. And so we need to go further. We hope that we can encourage them to get there. I suspect they would say there's some issues that America has to deal with, and fine, we'll try to get there. I think right now they've got the best chance they've had in a long time in President Joe Biden to try to get there.
Let's move on to some domestic issues. Some states are trying to deny gender-affirming care. What do you think about that? What can be done about it?
I thank the Eighth Circuit Court of Appeal that just came down with a decision that overturned a new state law that said that gender-affirming care would be banned in that state. No doubt the state will appeal, but the court was simply reflecting what pretty much every medical professional and medical organization out there in America has said, that gender-affirming care is not only validated care, but it also keeps people healthy and it saves lives. And so we're out there, we're gonna do everything we can to make sure that we continue to offer Americans the health care that they have a right to get, and that includes gender-affirming care.
So can you give us some behind-the-scenes insights into what, I failed the last time, so I'm going to try again, into what the Biden administration plans to do to support those actions?
Well, we have issued some guidelines that say that a provider who receives Medicare funding, Medicaid funding, must be prepared to offer gender-affirming care. We unfortunately ran into a couple of circuit courts that said differently, and so we're now in the process of having to work under those rulings. But we're not going to stop everywhere where we have an opportunity at the federal level. And again, I go back to yesterday's conversation where we don't control health care. We don't control how gender-affirming care is provided or if it is provided. But where we have laws that require you to fulfill your obligations, if you want that Medicaid dollar to come to your state, we're going to make sure you check the box.
Are you feeling hopeful that that will succeed?
Look, I'm the son of immigrants. Optimism runs in my DNA. So am I hopeful? I absolutely am, because this is not the America that we're supposed to have. Yeah, I think we're going to have better days, not just in this, but on reproductive health care. We're just going to have better days. I never took to public service to exclude. I never took to public service to discriminate against. And I don't believe that's the gene that drives America. And so I think we're going to get there. It's just going to take some time and a lot more activity.
Saturday is the first anniversary of the Dobbs decision that reversed Roe v. Wade, and we were here all together that day. A year has passed. It's had an enormous impact. Was it what you expected? The impact over the past year, is it what you expected?
Yes and no. Yes, in that there were going to be devastating consequences, and sometimes you actually hear about them in the news. No, in that I was surprised by the electorate when last November, when some ballot measures were on the ballot for folks to vote on whether to continue to ban access to abortion care or to make sure you affirmatively make it a right to have that care, that all the initiatives that were for affirming reproductive health care won. And I was not prepared to see such good results. So difficult times, but as I said, it's a march, and I think we're going to get there. I leave here to go to St. Louis to be at the same Planned Parenthood site I was at last year when the Dobbs decision was announced. And we're going to see where things are today. And it was important to go to St. Louis because that Planned Parenthood site was the last site that was offering abortion care services at that time. And when we were there, we had just finished a session, and right after we concluded, the word came out that the decision had come in. And within moments of that, they were already beginning to take calls telling patients that they were going to have to cancel some of these appointments. And then, of course, just less than 15 miles away in Illinois, different circumstance altogether. The state of Illinois still continues to offer the care the way it did before Dobbs, and it continues to do it today, a year later. And so it's just difficult to believe that that's the tale of America, the tale of two cities. And so that's why, as I said, I think we're going to get there. It's just going to take some time.
You've been in politics and policy and service for a very long time. You mentioned those votes that were in support of reproductive care. Do you think those will translate to voting in state legislators who will support reproductive care, or is there sort of a divide there?
If we're smart, yes. I don't know. You can answer that better than I can because you're in these states and voting. I would hope. Isn't it kind of interesting how it takes an incident to hit you at home before you begin to see how important it is generally? AIDS, HIV. Before, there were people who were completely against supporting those who had contracted HIV and AIDS, until, of course, it hit their son or someone they knew very close, and all of a sudden it was, no, we got to do everything we can. This is someone I've known since he or she was born. And it's unfortunate that you have to wait till someone says, yeah, that 10-year-old had to cross state lines in order for her to get an abortion because she was raped. But if that's what it takes, that's where we got to go. Keep marching.
Speaking of AIDS, I'm going to be speaking with Dr. Fauci and Senator Frist later about the PEPFAR program, which is really a celebrated program that has saved tens of millions of lives, giving HIV drugs to people around the world. We managed to do such a great job with that, but there are people in this country who can't afford their medicines. Talk to me about what the Biden administration is doing about that.
Well, it's a sea change. Anyone in this room who knows someone who needs insulin knows that, because so many Americans were paying $100, $200, $300, maybe more dollars a month to get their supply of insulin today. Certainly, of course, if you're on Medicare, it's $35. That's it. The price of medicine is just way too high in this country. We pay 2 or 3 times for a drug, a prescription drug, here than do folks in other countries. It could be the same drug, exact same drug, and in fact, in many cases, manufactured by an American company. And we still pay way more than most people do. And so the President's Inflation Reduction Act, I call it his prescription drug law, now for the first time lets us really go after high prescription drug prices. So insulin capped at $35. Better news, those of you who are Medicare age, you know about this issue with shingles. When you're younger, you don't have to worry about shingles. The older you get, shingles starts to hit. Just look up shingles. You do not want to get shingles. That could cost you about $180, $200 for a vaccine shot. A lot of folks said, I can't afford it. I'll just take the risk, try not to get shingles. Until you get shingles and you say, why did I do that? $0 today to get a single shingles vaccine. That's in law, in place. And come September 1st, stay tuned, we will announce the first 10 drugs that the United States of America will actually be allowed to negotiate to get the best price of that medicine for Americans.
I think a lot of people don't know that the United States couldn't negotiate. Can you talk about that a little bit?
It was written in law. We could not, by law, try to negotiate to get the 330 million Americans the best price for medication. And the law changed that, although the law limited it to only Medicare beneficiaries. It was supposed to be for everyone, but we couldn't get the full 60 votes necessary out of the Senate to keep everyone, or drug prices for everyone, negotiated. And so we were only able to keep Medicare. And so for the 65 million Americans, I will now, as Secretary, have an opportunity to engage in price negotiation with drug manufacturers. We're going to start with 10 drugs, and you can imagine they're going to be 10 drugs, very high priced, that are very essential. And then next year we get to add another 15, and then we add another batch every year. We keep going. And hopefully Congress will get smart and say it's not just for those who are 65 and older or are disabled. It should be for every American to be able to benefit from lower drug prices. And so we'll see. Although I think it's important to mention that we're already being sued in trying to implement that law. I haven't yet told you who's going to be part of the negotiation, but I've already been sued 4 times.
Your name is on a lawsuit, on 4 different lawsuits.
My name's on the lawsuit along with other of the government players, pharma, the pharmaceutical industry, American Chamber of Commerce, Merck, and somebody will yell to me the 4th. There's another, well, pharma, U.S. Chamber.
BMS.
I think it may be Bristol Myers, but I don't want to say it is unless it really is, because I don't want to get in trouble. But 4 lawsuits have already been filed, and we haven't yet even announced what the negotiations will look like.
They wanted to get ahead of the game.
Yeah, this is going to go to the Supreme Court.
Yeah.
They are dead set against letting us negotiate. I mean, who in America wants to pay sticker price? Do you ever shop for a car? Do you go to a dealership and say, oh, I see this is the price for your vehicle. Okay, this is what I'm going to pay you. No, you get in there and say, that's sticker price, but I did my work. I went to Consumer Reports. You're charging me way too much. This is what I'm willing to pay you. They come back and they finagle you, and you end up with a price, but you negotiated. As I tell folks, negotiating in America is as American as apple pie, and it's part of the market-based system we have for our economy. And so why would we not want to negotiate to get the best price? Why not use the leverage that the federal government can provide so that 330 million Americans can get the best price? Why not at least get the price that they're giving to those other people in these other countries around the world, but they're not giving to us?
Funny you should mention shingles vaccine. I mean, not that shingles is funny. It's not funny at all. I know it's not funny, so I tried to get vaccinated when I turned 50 a number of years ago. I still can't get it. I can't find a place to get an appointment. I make an appointment and they cancel it. My mom, who I'm honored to have here with me, she couldn't get her second shot. I mean, I know many people, because it is one of the many drugs that are in shortage in the United States. You hear about it more and more from just grassroots, people talking about, my mother couldn't get her cancer drug, my father couldn't, whatever. What is being done about that?
And too bad Commissioner Califf is not here with FDA, because he could tell you the number of things that we're trying to do within the FDA. But again, remember, federal government, we don't manage healthcare for everyone directly. We have to do it indirectly, whether it's through Medicare, Medicaid, Obamacare. There are 2 issues with regard to drug shortages. One is, this is what happens when the market drives supply and price. And if you're all now familiar with the way supply is driven, it's all based on just-in-time inventory management. So companies, to save cost, will order only enough that they can keep in inventory so they can turn over their supply quickly, because it costs them money to store it. And so they only store as much as they think they're going to need, and they try to forecast what they'll need. Well, sometimes something happens. And it's a market failure for an industry to play that game of just-in-time inventory management when it's not a widget, but it's a life-saving drug. And this is what we see happening today, is too many drugs are in short supply because the industry doesn't want to do more to have more of those drugs available, whether it's the providers, the hospitals, or whether it's the retailers, or whether it's the manufacturers. Everyone wants to save a buck, so they're only going to put out what they need to and buy what they need to. The second failure is, again, when you don't give anyone oversight over this to really be able to manage these players who are all out there trying to make sure they can make as much money as possible or survive economically, it becomes very difficult. When I became secretary, I knew I was going to deal with the pandemic. I knew I was going to deal with Medicaid, Medicare, and all this. Did I expect that I was going to be involved in infant formula? When there was a shortage of infant formula, who did everyone look at? federal government, the Biden administration, Mr. President, what are you going to do about the shortage of infant formula? Well, then from there went to, okay, well, that's got to be healthcare. It's not DOD. And so they came to us. And because the FDA does regulate what formula can be put out there because it's got to be safe. They said, well, you sort of regulate it, you should know. And of course, we don't produce infant formula. We can't direct a manufacturer to make more or to keep some in supply. And so the difficulty is we don't have the levers to deal with shortages the way we need them. And that's what happens when you don't have an overarching system to oversee things like healthcare. If we treated healthcare the way we treat electricity, public education, potable water, in a very different circumstance. When you flick the light on in your house, if you pay your bill, you're going to get electricity. It's not a matter of just-in-time inventory of electrical generation. No, that electricity company is making a profit, a guaranteed profit, because they're regulated. But they have to guarantee that they'll make the supply of electricity available to everyone. That's why they don't have to worry about hustling to beat somebody else on the price of their electricity, because they know they're going to make a fixed profit above what their costs are. But that's a regulated market. Drugs are not a regulated market. Infant formula is not a regulated market. And that's what happens when you have a system of healthcare that doesn't give you a national overarching view of it. And that's why so many of us have forever talked about how it's so important to make healthcare a universal aspect of our life, not a widget, a commodity that's up for the highest bidder.
So for infant formula, the approach was, let's fly in a bunch of formula from other countries. I was at Ramstein Air Force Base when those planes were leaving, and you folks flew in lots and lots of formula. Could that approach be used for, say, one of the cancer drugs that people with cancer are being told, sorry, you can't have your chemotherapy?
Yes, if there's enough of the product in other parts of the world. And if there's a shortage in America, chances are there's a shortage in other parts of the world. The reason there wasn't a shortage of infant formula in other parts of the world is because other countries regulate infant formula in terms of making it available for sale, retail sale, differently. We have higher standards than most because we believe that an infant should not be given formula tainted with arsenic, certain levels of arsenic. And so it's a little higher standard. But what we did was we essentially did the job of the industry. We flew in product from all over the world because they weren't producing enough for domestic consumption. We essentially paid for them to have a supply available. Because once we brought in that product from all over the world, we didn't distribute it because we don't have a distribution chain. We gave it to the market, we gave it to the industry.
So why not do that with drugs? I mean, it's just because it's in shortage here does not necessarily mean it's in shortage in other countries.
Because you have to know that there is that supply available elsewhere. Talk to Canada about whether they want to give us all the drugs that we think we need, given that the price in Canada for these drugs is far less. They will. I've had many a conversation with the health minister and others there. They want to be helpful, but they don't want to have a shortage on their end. And so it's not so easy. And it's not, honestly, it's a very simple solution. Everyone, if you're going to be responsible to provide a life-saving treatment or a health-saving treatment, you can't treat it like a basic commodity. It's not like a chair or the spark plug for your car. No, your kid needs that today. Your infant needed that specialty formula today. It should be available. And if we're going to let the industry dictate that availability, they have a responsibility to do it right. Otherwise, they should let us come in, do more regulation to make sure it's done right. But again, give them something in return, guaranteed return on their investment. There has to be some way we deal with those things that we consider indispensable. I don't know about you, but I think infant formula is indispensable. I think most prescription drug medication is indispensable. I think electricity is indispensable. I think public education is indispensable. And I'm not going to let the highest bidder determine who gets access to whether it's public education for my child or that prescription medication.
So can you be as specific as possible? What levers can be pulled when a drug company says, I mean, they never say this publicly, but it's clear that many of these drugs that are in shortage are very inexpensive drugs. They are not making, I mean, Ozempic is not in shortage, right?
Yeah.
They're making sure they have plenty of that. It's, well, maybe for people with diabetes, but I mean, when people are willing to pay the price, they get Ozempic. But many of the drugs in shortage are very, very inexpensive. What levers can be pulled so that they will continue to make a drug that doesn't make them a lot of money?
So FDA right now is actually working with the industry to trying to figure out if we can accelerate approval of some of the medication. So without shortcutting the process to make sure they're safe and effective, that's their standard, safe and effective, we're accelerating the approval process. So we're going in and doing the inspection and oversight in a faster way, which by the way means there's another product or service that's not getting the attention because we have to pull people to do that. But because there's a shortage, we're doing that. Again, we're helping the industry cover for not having been responsible to do their job. We're also seeing if there's a possibility of bringing product from abroad. But that's also, it has difficulties because how do we make sure that that product, that drug has been produced safely and effectively if we weren't there to do the oversight? Because all those drugs that are manufactured here go through a process where they have to get checked to be sure that they've been safe and effective. That's what happened with infant formula. We found that some of these plants were infected or had evidence of infection. So these batches of infant formula couldn't go out. We were there to inspect. How do we do that with product that was manufactured abroad where we are not there to inspect? We're also looking at expanding our abilities to do inspection overseas as well.
But you did it with infant formula. I mean, right, so it is.
Because we had to.
Right, but it is possible to do it with drugs.
Yes, it is.
Yeah.
I can tell you the expense. It's very expensive. And it also takes you away from other very important activities. FDA had essentially tell folks, you're going to leave what you're doing to come over here and do this because we don't want to reach crisis mode. That should not be the way FDA operates. That's not the way the American public should allow industries to operate that don't want to have more oversight about the way they operate. Because it is not fair for the work that's being done by FDA to do it right, to be told, hurry up, get it out there, shortchange others who are waiting in line to get their products approved, simply because an industry decided they don't want to have more in storage than necessary because it costs them too much to pay for that warehousing of the product. We're now looking at ways that we might be able to pull a lever. Again, we don't run healthcare, but you want to get a Medicare dollar reimbursed as a provider, a hospital, you get Medicare dollars. Show us what you're doing with your drug supply. What kind of supply do you have? And if you're doing something to keep a supply of drug available, maybe we'll reward you for doing that. And those who don't, maybe you won't get at least a reward. And everyone wants a Medicare dollar, or at least more of it.
Let's talk about mental health care and in terms of parity with health care for non-mental health issues.
We're not there. We need to get to the point where when we say health care, we mean all health care, not just physical health care. We have a law that says we're supposed to treat mental health on par with physical health, so that when you go in to get a service, your provider will be there with a professional to give you that service, and your insurer will cover the cost for that service. Again, 50 countries, 50 states, 50 different ways to do this. Some states do it better than others, but we're not there. We're far from it. And we don't have the workforce in place to really deal with some of the mental health challenges that we're facing. I said it yesterday, I think 9 in 10 Americans, when they're surveyed, say that America has experienced a mental health crisis. You have preteens who are, in some cases, committing suicide, but the suicide ideation rates of preteens have gone way up. And I mentioned 988, the program that allows you to call if you're in distress, mental distress. The number of people who are calling, it's It's alarming.
That service went into effect, when was that?
July 2022.
Okay, so it's been almost a year.
Year,
Yeah. Have the numbers, do you think that people know, I mean, everyone knows 911. Have the numbers, do you think people are aware about that number and
Oh, yeah.
Okay.
The numbers are way, way up. We increased the numbers. I'm not going to get the statistic right, but we increased the numbers by, I think, at least 50%. The numbers of folks who are texting have gone up, I think, over 1,000%. And that's because I think young people are feeling more comfortable reaching out now because they can text and chat instead of making a phone call. But it's absolutely working. Now what we have to do is make sure that if they're willing to take the correct fork in the road and make that call, that we can do the follow-up care as well. Because you can save the life in that call, but once you hang up, will you be there for them when they need you? And that's what we're trying to do, is make sure there's follow-up care.
I mean, friends of mine who have sought mental health care for their children, I mean, not to mention for adults, it is so hard to find a bed. It is so hard to find a practitioner. And I know that you're not in charge of healthcare, but is there anything that the Biden administration is doing to try to free up some resources?
We are, but there's something very important what you said, Elizabeth. Some of your friends. I suspect some of our friends have done the same thing, and it may take a while, but our friends are able to finally get the care. I can take you to places where the friends of some of these folks never get the care. And it's mostly in Black and brown communities where they're just going without care. And it is difficult when you have to wait 2 months to have your child see someone who you know you desperately need to access. It's worse when you don't even try because you don't know who to call or you don't believe anyone's going to respond. And that's why, by the way, in this 988 phone number, we set up a dedicated line for veterans, a dedicated line for LGBTQI plus individuals, and we set up Spanish language call centers, because we don't want anyone to say, why should I call? And so we're doing what we can. We have put more money into mental health under President Biden than I'd say, and again, someone will fact check me on this, but I'm probably going to be right, than the last 3 presidents combined. Just the money in 988. The year before President Biden came in, I believe 988 the federal government invested about $20 million, $22 million into helping establish 988. So far, President Biden in his 2 or so years has put in, I believe, over $750 million into helping stand up 988. Again, we don't run it. It's the states. But unless you put some fuel in that tank, you won't be ready. And we were not going to allow July 16th come and not be ready, because the worst thing you could do is have someone say, I'm about to take the wrong fork in the road, I'm going to make one last try, and you call and you get a busy signal. Or someone says, yes, suicide prevention hotline, can you please hold?
So in addition to 988, what else is the Biden administration doing? You mentioned money, but specific programs, specific efforts to improve mental health, right?
So we are working with states to try to increase access to mental health services in schools. We are trying to promote and encourage states to apply for what we call waivers within the Medicaid program to allow schools to actually receive Medicaid dollars. Remember, Medicaid dollar must go for health care. And we're working with states to see if their schools can apply to get Medicaid dollars directly by checking the boxes that show that they are providers of health care. And so if we can do that, we can get a school that will get reimbursed for having a psychologist or some kind of social worker available, or even a nurse available at the school to help these kids at the site where they are 5 days of the week. We're working to try to help expand the workforce in mental health services. We're directing some of our Public Health Service Corps money. Public Health Service Corps is an organization of health professionals. They are the ones that respond. They're like our first responders, COVID and natural disasters. We're expanding the numbers of those folks. My son-in-law is a pediatrician today. He got 4 years of medical school paid for, part of the Public Health Service Corps. He now is committed to serving for 5 years in an underserved area of the country, so he's giving back that way. We're expanding the numbers, and we're trying to locate some of those in areas that are deficient in a number of professionals, including mental health professionals. We provided about $100 million last year in grant money to help those states that are trying to help relieve the resiliency problem of the healthcare workforce. A lot of folks are dropping out, leaving healthcare because it's just so high burnout. And so we're doing what we can, given that, again, we don't control. And unless we come with a dollar, we can't get them to move.
Let's talk about Medicaid redetermination. This has been an issue of late. The possibility of people losing their Medicaid. It's complicated. Can you explain it and then explain what can be done?
Medicaid is an eligibility program. You don't get it unless you can show that your income is low enough and you meet the other criteria. COVID hits. Federal government says it's crisis. In fact, working people were losing their jobs and their health insurance. So the federal government said, we're not going to ask states to take applications from folks to find out if they're eligible to be on Medicaid. If they're on Medicaid, as of this moment, they stay on Medicaid. No need to reapply it. You have to reapply every year. 3 years passed before we finally took down the public health emergency by removing the declaration on a public health emergency. The protection to keep Medicaid for everyone available without applying disappeared as well. So now we're in this process called redetermination. States have to redetermine if those who are receiving Medicaid services are still eligible. Many will be, many won't. They have their own jobs, they have insurance through their employer, so forth. There are numbers, we've estimated somewhere between, 15 to 17 million Americans who receive services, healthcare services through Medicaid. By the way, we're at about 92 million people in America who receive healthcare through Medicaid. Half of America's children get their healthcare through Medicaid. About half of births in this country are paid for or helped through Medicaid. And we know that about 15 to 17 million people are likely to lose their Medicaid coverage unless we work hard to make sure they know. Because for 3 years, states were saying to folks, don't worry, you don't need to open that envelope that says Medicaid on it because we're not going to ask you to reapply. And so a lot of folks aren't opening their mail. Simple as that. And some states aren't doing as good a job as they can to hustle and find out if folks qualify or not. You could qualify for Medicaid again. Maybe you don't qualify for Medicaid, but maybe you're now eligible for Obamacare. We have hit it out of the park on Obamacare. Today, there are more than 16.5 million Americans who have their health insurance through the Affordable Care Act. And with the subsidies that we're providing, many people are paying less than $10 a month in their premiums. And so we're telling them, have you checked out the marketplace? Can't get it there? Maybe you're working. Maybe your employer provides it. We know that a good number of those folks who may drop are eligible for some level of care, and we just don't want to see anything happen. So I've been issuing some letters to governors of the 50 states saying, this is what things look like in your state. Can you do more? We've provided them with all sorts of flexibilities to do more, to procedurally get them folks to reapply. We'll see where we go, but it'll be a sad day when millions of Americans no longer have the coverage they had to stay safe.
Secretary Azar said last night that, your predecessor, that your job, the job of being the Secretary of Health and Human Services, is quite powerful, but also quite weak. Can you talk about that in terms of gun violence? I imagine your heart breaks just like everybody else's when there's another mass shooting. But your heart is in the body of someone who is in a position to maybe do something. Is there anything you can do?
We do some things, but it's very difficult at HHS. Remember, there's still laws in place that prohibit doing research on the impact of guns on health. It has only been recently that HHS has been able to undertake some levels of research to start to collect the data that help us better, target our support and resources. We do a number of things. We do, as a result of the Bipartisan Safer Communities Act that resulted from some of the mass shootings of last year, we have been able to distribute some money to schools to help them try to provide mental health services to kids who either experienced gun violence at the school, or for schools that are trying to help kids be prepared, which is kind of sad to say, for some of this. But it is very limited. We have declared at HHS gun violence to be a healthcare crisis. But again, that doesn't come automatically with money. We need Congress to help us. And I go back to what I said before. We can't force states to do something because we believe gun violence is a healthcare crisis. They still at the end decide what they do with gun violence in terms of healthcare. And we may come with $1, and that may entice them, but when Congress doesn't give us more money, it's tough to move that dial a lot.
Thank you very much, and we're going to move on now to questions and answers, or questions rather, from the audience, answers from him. All right, so the gentleman there.
And if they give us their name.
Yes, tell us your name.
My name is Dr. Elliot Levy. I'm a retired physician, and I've gone from providing healthcare to now being a consumer of healthcare. And one of the major problems that I see that you both referred to is access to healthcare. And I think it's a terrible problem affecting people who have insurance, who have money to pay. They just can't get in to see a doctor. Are you aware of this issue, and do you have any ideas about what can be done?
So we know there's an access issue, and it plays out all over the country. I used to tell folks when we were talking, when we were trying to pass the Affordable Care Act back in 2009 and 10, people kept talking about the disparities between, this was on Medicare, between some of the northern states that had really low Medicare reimbursement rates compared to some of the southern states that had really high Medicare reimbursement rates, and that disparity was not fair. And what we try to point out is the disparity was due principally to health status. But to your question, access, and I was going to use that to point the example. In LA, where I've called home for a long time, you can go to Beverly Hills and have access, and you go to East LA or Compton and not have access. Yet those physicians, especially those specialty physicians, aren't far away. Now, you may find access issues even in Beverly Hills because there's a high demand for that service, but it'll be a different access issue than those encountered by folks who live in East LA and in Compton, where their access issues due mostly to the fact that there are no providers there, or no providers that are willing to provide the care because the reimbursement rates are too low. We have a healthcare workforce which is fairly large. It's just not well distributed. And once again, you could imagine where you have the higher numbers of health professionals, especially in the specialty care areas. It's in places that are willing to pay bigger bucks.
All right, let's see. Right there. Could you? Yeah.
Hello, my name is Sahi, and I'm here on behalf of Tulsa Innovation Labs. You spoke briefly about how you guys are viewing mental health care for students who are affected by gun violence, and you talked a little bit about using that as a post-intervention, but do you guys think about mental health care and its establishment in schools across America as a preventative measure to be on the lookout and be able to catch those signs? Because a lot of these perpetrators are mental health patients, for lack of a better term.
We absolutely do, but again, and see, even in your question, the implication is there that we drive how mental health care is done nationwide. We don't. We try to move it in ways, but it's tough as I said, unless you've got some dollars. For me, waiting until the incident, the violence occurs, is always, I mean, it's tragic to wait till somebody is killed or harmed by violence, gun violence especially, to try to then treat them. But it's also extremely expensive for our economy. And one of the smartest people I know, one of the wisest people I know, my mom would always tell me, mejor prevenir que remediar. Better to prevent than to remediate. And so we're all about trying to prevent. Just we have to have players on the ground in those states willing to prevent with us. And usually they'll say, we'll do the work if you give us the money. We can only give so much of the money. Because if we do it for you and your community, every other community in America is going to ask us for it. We don't have the money to do it everywhere. But we can try to seed you. We can try to promote that. We can help fund a great demonstration project to show how it can work. But we need the states to step in and believe that mental health care should be treated the way physical health is treated.
Yeah, okay. Right there? Yes.
Thank you very much, Secretary Becerra. I'm Seema Gandhi. I'm a physician, and I come with the immigrant, resilient, and positivity gene. My question is just changing the tone and bringing us to climate change. And I know we briefly talked yesterday about it, but a couple things you said. One is that the virus doesn't see any boundaries when you refer to COVID. Similarly, climate change doesn't see any boundaries. And the thing you said yesterday is, show me the data, show me the science, and HHS is the executor. We have unequivocally data and science on the impact of climate change on human health. So through your power to sort of impact CMS, my very specific question is, what is CMS doing to hold healthcare systems accountable to link that Medicare dollar? And I know you said multiple times you don't execute at state levels, but CMS does set the tone.
Yeah. And it would take longer than we have, I think, to try to respond completely, because CMS is a badass. They do a lot of really good stuff. They got a lot of money, and they essentially drive Medicare and Medicaid. And because so many health systems depend on reimbursement from Medicare, especially, but also Medicaid, where CMS takes Medicare, Medicaid could take a lot of the states. But it's an indirect way to try to take them there. And the authorities are limited. So CMS, if I defy you to find me where within the statutes that relate to CMS, you'll find a reference to climate change. What we have to do is show that climate change is impacting health and the health of the Medicaid or Medicare beneficiaries, and therefore CMS is taking action to make sure that those Medicare or Medicaid beneficiaries are having their health fully taken care of, which could include dealing with climate change. But you can see how many steps it took me to get you there. And I guarantee you some others are looking at that as well, and they're preparing their lawsuit to challenge us doing that. And so it is not as easy as you think. It'd be a lot easier if Congress just said, climate change is real, we're going to provide money because it's impacting the health and economy of the United States of America. Then we'd be able to go in without having to go through the more indirect route. But we are taking on climate change. I set up an Office of Climate Change at the Department of Health and Human Services first time. I also set up an Office of Climate Equity because I believe that there are already people getting hit hard now by climate change. We have, it wasn't until President Biden stepped forward and made, I think it was more than $100 million available to Montgomery, Alabama, to deal with the crisis that they had as a result of some of the natural disasters that hit, where they could no longer use their water supply lines, and there wasn't enough action being done at the state level to address that for the hundreds of thousands of people that live there. So the federal government stepped in. We can't do that in every community, but the president thought that was important. That's why the federal government stepped in Flint, Michigan, where action wasn't moving quick enough to clean those lead pipes out of the system, because again, most of the folks drinking that water didn't look like most of the folks in this room. And that's why today there's still issues in my great state of California, where you can go into the Central Valley And people will take you to their home and they'll open up their tap and nothing will come out because the wells are dry. And they have to go buy bottled water, not just to drink, but to try to help bathe their kids. You know how expensive it can be when you're living on a fixed income to try to have water so you can just bathe your kids? That's where we are. Climate change is real.
Climate change is real. I think that is a good sentence to end on. Thank you so much, Secretary Becerra, for joining us today.